Hi, I'm Hannah Lehman, and I'm the founder of Philadula. Today we're going to be going through a module on normal values. What are normal values? Normal values are the range of values related to conditions in the body, let's say pulse, blood pressure, fetal heart rate, and we're looking at the normal range, right? So, what is considered safe for a pregnant person and their baby, right? Again, these numbers and this information is not meant to be any kind of medical advice. It's just meant to inform you so you have some background on how to support your clients in an evidence-based manner. So in this module, we're going to cover normal values for pulse, blood pressure, gestational diabetes or blood sugar, fetal heart rate, amniotic fluid levels, and what would be considered normal in terms of the color of the amniotic fluid if your client's water breaks. Right? So why is it important to learn normal values? First, we can help our clients seek medical care if they notice abnormalities. Second, learning that range of normal will give you the ability to translate the meaning of the numbers to your clients so they can understand what is happening in their body and make informed decisions. And lastly, in critical moments when interventions are being encouraged, you're going to be able to better recognize the general level of urgency or whether it makes sense to make more space for your clients to ask questions or ask for alternatives. So we'll start with maternal pulse and what is normal. Resting heart rate actually increases during pregnancy. It can increase 10 to 20 beats per minute because that heart has to work harder to pump more blood to the uterus as that fetus grows. By the time of birth, they're pumping 30 to 50% more blood, right? This increase can cause heart palpitations or the feeling of fluttering in the chest or a sense that their heart is racing. Irregular heartbeats are also more prevalent and normal in pregnant people. They're just doing so much more work. The normal values for maternal pulse during pregnancy are going to be 60 to 100 beats per minute. Again, a maternal heart rate can increase by 10 to 20 beats per minute. For example, if someone's pre-pregnancy rate is about 70, it can sometimes reach 90 and still be within normal range. However, a resting heart rate above 100 or below 60 is usually considered abnormal during pregnancy. Sometimes it's the hormonal changes that also trigger the abnormal heart rhythm. That's about 10% of cases. Here are some possible causes of abnormal pulse. So for that range that is higher than 100, we call that tachycardia, right? That can be caused by dehydration. So reminding your doula clients to drink a lot of water is really helpful. Anemia, anxiety or depression, caffeine intake, foods that are high in carbohydrates, sodium, sugar, or fat, extra weight or obesity, or existing heart conditions. That lower range, so lower than 60 beats per minute, is called bradycardia. That can be caused by preeclampsia, anesthesia like an epidural, hemorrhage, so bleeding too much, supine inferior vena cava compression, so when someone is maybe laying on their back for too long, and the weight of their uterus is compressing the blood flow. Certain medications can lower the BPM, and then other underlying medical conditions. So those are some of the possible causes. I find that the most common that I see is going to be the dehydration for the tachycardia, and the lower range would be because of the epidural. So almost always someone's BPM is going to decrease when they get an epidural. That's why, just as a reminder, they give people a big bag of fluids beforehand so that we don't have any complications. All right, so how do we take someone's pulse? Again, it's between 60 and 100 that we're looking for. The way you're going to take it is by placing 2 fingers on the side of the neck or the wrist and find the spot where you feel that pumping of blood. It'll feel like a heartbeat. And then you're going to count how many beats you feel in 10 seconds and then multiply by 6. I'd recommend doing this 3 times, so repeating that test to confirm. This is also something that you can teach your clients so they can pay attention to it if they're feeling unwell, right? During labor, especially at a hospital, they may use a pulse oximeter to track a birthing person's pulse. The reason is that a birthing person's heart rate will usually be lower than the fetal heart rate. And if they notice that the fetal heart rate is low on the monitor, they're going to make sure that they're not picking up the maternal heart rate instead. And that they'll do that by putting a pulse oximeter on the birthing person's finger or toe. If someone is birthing out of the hospital, they will also track this if they notice that the baby's heart rate seems to be a little bit too low. And they'll just do that by taking the pulse, just like we showed you. Next, we're going to move to maternal blood pressure. This is a really important one because having high blood pressure is a big reason why many people are induced these days. So, what is blood pressure? So, blood pressure is the force of blood pushing against the walls of blood vessels called arteries. The arteries bring blood from the heart to your lungs, where it picks up oxygen and then moves to your organs and tissues. The organs and tissues use the oxygen to power their activities. Blood vessels called veins then return the blood to the heart. And that's from ACOG. So, why is high blood pressure a problem? During pregnancy, uncontrolled high blood pressure can cause less blood flow to the placenta. Less blood flow to the placenta can result in the fetus receiving less oxygen and fewer nutrients, which can result in IUGR, so intrauterine growth restriction, or premature birth. Both are complications that we do not want. Severely high blood pressure or preeclampsia can cause extra stress on heart and kidneys, which can lead to heart and kidney disease and stroke. So severe things can happen when the blood pressure is very, very high. Chronic hypertension pre-pregnancy, so if someone has high blood pressure issues before they even get pregnant, that is also correlated with the chance of placental abruption. So what do these numbers mean? You're going to get a reading that has 2 numbers, so the systolic and the diastolic. Systolic is going to be on the top or told to you first, and diastolic will be on the bottom. So a blood pressure reading that has 2 numbers, it's usually separated by a slash, and an example would be 110/80 millimeters of mercury. They don't usually say millimeters of mercury, but you just get 110/80, right? So the systolic pressure is the pressure against the artery walls as the heart contracts. Diastolic is the pressure against the artery walls when the heart is relaxed in between contractions. Here's a nice picture of it. You can see the systolic pressure as the arteries are contracting, and then the diastolic is kind of as that heart is at rest. So what does that look like? The garden hose analogy can also make this easier to understand. Systolic is that higher number again. That's the pressure inside the hose when you turn the faucet on full blast. So when the heart beats. Diastolic, that lower number, is the pressure inside the hose when the faucet is just barely on. So when the heart is at rest. So we're looking at both of those states of the heart to see how it's doing. Here are the guidelines for blood pressure. As a doula, I want you to remember 140/90. That is sort of the lowest or the minimum for kind of a preeclamptic range or a high blood pressure range. So that would be a red flag, 140/90. Memorize that number, right? And here are some of our blood pressure ranges ranging from healthy to hypertension, right? So healthy, we'll see a systolic blood pressure range of less than 120 and a diastolic of less than 80. If they start to get elevated, we're seeing 120 to 129 and less than 80. Stage 1 hypertension is 130 to 139 and a diastolic of 80 to 89. Stage 2 hypertension, so we're going up in intensity, right, is going to be that 140 or higher and that 90 or higher for diastolic. When we're in crisis, so hypertension crisis, I have not actually seen this in any of my clients yet, but the most severe is going to be over 180 for the systolic or over 120 for diastolic. Right, so again, what you need to remember is this sort of guideline, 140 over 90 being sort of that stage 2 hypertension potential for preeclampsia number. So 140 over 90 is the one that I want you to remember as a doula. All right. So we're going to compare chronic hypertension to gestational hypertension, right? So chronic hypertension is having a blood pressure that is over 140 for systolic or 90 for diastolic. So 140 over 90, again, it's coming back before pregnancy, before 20 weeks gestation, or for 12 weeks or longer postpartum, right? So that's chronic. Chronic means that it happens over a long period of time, or maybe you had it before getting pregnant. You're going to be labeled as having chronic hypertension if you were taking blood pressure medication before getting pregnant, even if your blood pressure is well controlled. So you're still going to be, treated as if you have chronic hypertension, even if it's well controlled with medication. The treatment for chronic hypertension is going to be a recommended induction between 37 and 39 weeks gestation. And they will have you start taking breastfeeding safe blood pressure medications during your postpartum, right? Because postpartum preeclampsia is still a possibility. It's not like the baby comes out and then, all is well, especially for people with chronic hypertension. It's something that we want to pay attention to, right? It's not a great state. Gestational hypertension is slightly different. It means having that blood pressure that is greater than 140 over 90 after 20 weeks pregnancy. Often in the later portion of that third trimester is when this starts to develop. You don't have to have any issues with blood pressure prior to pregnancy. The recommended treatment is often going to be monitoring for signs of preeclampsia, weekly non-stress tests to see how the baby is doing, so that the fetal heart rate, fetal movements, your blood pressure, obviously. Very simple things that we want to keep track of. An induction may be recommended if we start seeing those blood pressures grow and any other signs kind of moving into that next stage of severity or true preeclampsia going up. So we talked a little bit about preeclampsia, but let's dive in. So the definition of preeclampsia is high blood pressure with proteinuria or new development of decreased blood platelets or abnormal kidney and liver function with fluid in the lungs. So the cause is generally placental blood flow. So a lot of these issues kind of go back to the placenta and how well the placenta is functioning. They'll do some testing after, you get those high blood pressure readings. They'll take 2 blood pressure readings that are 15 minutes apart. And if both of those are over 140 over 90 or at 140 over 90, then they'll usually recommend that you do some extra testing to see if we're in that preeclamptic range. Preeclamptic just means pre-seizure. So I know that's kind of a scary word, but at this point, we're trying to prevent going into that more extreme state, right? So the testing for this is going to be doing a urine test. They're looking for protein, which would be a sign that that level of blood pressure is affecting other organs, right? So different people have different tolerances, but seeing that protein in the urine would let us know that this is actually affecting your the larger system of your body. It's time to act and do something. They may also test your liver and kidney function and platelet count. There are some symptoms that you could educate your clients about. One would be vision changes, sudden swelling, headaches, and obviously the experience of seizures. Treatment options for preeclampsia are usually going to be induction, right? And that's usually pretty soon. You'll come to your appointment, If they diagnose you with preeclampsia, they're going to want you to go straight to labor and delivery. You may have a little bit of wiggle room depending on where your blood pressure is to go home, pack your bag, take a shower, eat something, and then come in for that induction kind of later in the day. But if things are really severe, you're not going to have that, right? One thing that could help you during your labor to help bring your blood pressure down is by actually getting an epidural. So that is one of those options, and that I would probably try before trying the magnesium. Sometimes they have to go straight to giving you magnesium sulfate, and that's usually through an IV drip. But that can make people feel really fatigued, really groggy for days after, and you just don't feel like you can move at all. You feel just kind of out of body. So, not a very pleasant experience. So, if we can avoid doing the magnesium, that would be amazing. Of course, in certain situations, it's really our only option to keep you safe. So, we try the epidural first, right? And then we always have magnesium to fall back on if we need it. All right. So, one good question that I get from my students is, there's normal pregnancy swelling and then there's preeclamptic pregnancy swelling. How would you know whether or not you're swelling because of something that's dangerous or just something that's normal in pregnancy? So normal pregnancy swelling is going to develop gradually. It usually only affects those lowered limbs, so like your ankles and your feet get kind of swollen. It gets worse at the end of the day or after standing up for a long time. Usually it gets better if you rest, you elevate your legs, and then you kind of see it go away, right? Preeclamptic swelling is a little bit different. So it may occur suddenly, it can affect the face and the hand, and it may occur with those other symptoms. So, like persistent headaches that don't go away with over the counter meds, vision changes, those kinds of things would be warning signs to me as a doula that would kind of encourage me to recommend that, those aren't normal symptoms. That's not normal swelling. You may want to go in and get checked. So, how can we prevent high blood pressure? In some ways, it can happen, and you don't have a ton of control over it. If maybe you're genetically predisposed, you're generally a really healthy person. Um, but there are some things that we can do to make developing high blood pressure in pregnancy less likely, right? So one would be a low dose of aspirin, start at 16 weeks. That's usually 81 milligrams a day. And this is highly recommended for folks with any other risk factors. And it is a low risk intervention. So if people who maybe are generally healthy want to have that as an added preventative measure, it's not a risky one to do. You can just add it in. It's also very inexpensive. For some people, calcium and magnesium supplements can lower their risk of preeclampsia, and this is especially if their calcium and magnesium are low, right? It makes the most difference with people like that, right? And then we have exercise, healthy eating, so low sodium diets, high protein, high fiber, those kinds of things. And then lowering stress. So stress can significantly increase blood pressure in individuals. So they're just a few things that can help your clients lower their chance of developing high blood pressure during pregnancy. Next, we're going to talk about gestational diabetes. So this is kind of a measure of blood sugar in the body. So gestational diabetes mellitus, or GDM, is a condition in which a hormone made by the placenta prevents the body from using insulin effectively. Glucose builds up in the blood instead of being absorbed by cells. 3 to 8% of pregnancies are affected by GD or GDM. You'll hear both. Researchers think that GD is caused by those hormonal changes in the body during pregnancy that causes insulin resistance and the body to process blood sugar less efficiently. Usually, GDM resolves itself at birth. Gestational diabetes has a range of severity. Most cases of GDM are managed by diet and exercise. But then in more severe cases, a pregnant person will need to monitor their blood sugar daily and give themselves insulin injections alongside dietary changes. There are a few risks associated with gestational diabetes. So basically, we're talking about like, why do we care about this? Why is this important to treat? So untreated and uncontrolled GD can cause increased risk of big baby or macrostomia, shoulder dystocia that is connected to having a bigger baby. So when you have a bigger baby, a baby that's like bigger than what your body would have normally made if it didn't have gestational diabetes, that could mean that that baby doesn't fit through your pelvis very smoothly. So the shoulder can get stuck. Right? So that's connected to having a bigger baby. It's also connected to preterm birth, fetal hypoglycemia, so low blood sugar, fetal respiratory issues, jaundice, stillbirth, diabetes, cesarean, and preeclampsia. So these are all connected, right? There are a few risk factors that would make someone at higher risk for GDM. So being plus size, being advanced maternal age, having a history of gestational diabetes in other pregnancies, having a history of having a large for gestational age baby, so maybe they didn't know they had gestational diabetes before, genetically having diabetes in a close relative, so that might predispose you to have gestational diabetes, or belonging to an ethnic group that is at increased risk for GDM. We do see a higher prevalence in Filipinos, South Asian people, Latinos, Black and American Indian populations. And that may be for a variety of structural issues too. People that are lower risk for GD are going to be people who are younger. So age younger than 25 years, being Caucasian, having a weight that is quote unquote normal before pregnancy, basically like a BMI of less than 25, not having close relatives with diabetes so it doesn't run in your family, no history of glucose intolerance so that you know your health history looks good when it comes to tolerating sugars, and no history of poor birth outcomes. So there's going to be some testing that your clients will have to go through for gestational diabetes. That typically happens between 24 and 28 weeks. They're going to do that earlier, though, if there's a pre-existing history of diabetes or if someone is overweight before getting pregnant, right? We all know that we gain weight, a lot of weight actually, when we are pregnant. But if there is a history of being a bigger person before getting pregnant, they may do an extra earlier test. There are two different kinds of tests. There's a two-step test, which is also known as the 1-hour test. So first you'll drink a very sweet, sugary drink that contains exactly 50 grams of glucose and usually tastes like flat orange soda. It's not very good. Then you wait for 1 hour before your blood is drawn and tested for glucose. If your glucose levels are too high at that point, you'll need to come back for that second step of the test, which involves drinking more of this glucose drink and having your blood tested at multiple intervals. There are some options for other things to eat or drink. Some people will order what's called like the fresh test, which is like a more natural version of this glucose drink, and that would be ordered specifically by your client. The hospital wouldn't order that for you. It's usually, $20 or something like that to order. And there are other ways, but you would have to kind of get the approval from your medical provider to do this option. Certain candies, like for example, eating about like 18 of the watermelon Sour Patch Kids would give you exactly 50 grams of glucose, and it doesn't have like extra things like protein that would change how your body is metabolizing that sugar, right? So you still need like a candy that is kind of like pure sugar, basically. So like jelly beans is an option. A certain amount of Twizzlers is an option, but it does have to be kind of exactly 50 grams of glucose. So it's a worthy conversation with your provider if you're like, ugh, this drink is disgusting. I do not want to take it. I would rather eat something that I like. That could be an option as well. You do have to eat it within like a 5-minute period. So it needs to be something that you can eat within 5 minutes. So you could eat 18 watermelon gummies in 5 minutes, perfect. But know you have some options and just have some conversations with your medical providers. So the other test that you may have to take is the one-step test, or it's also known as the 3-hour glucose test. You have your blood drawn first, then drink the sweet glucose drink or eat the candies, and then you'll have your blood drawn 2 more times over the course of 2 hours. So it's a lot longer of a test. They want to see kind of more details about how your body is processing those sugars. So a little bit about interpreting those glucose test results. What do they actually mean? So a blood sugar level that is below 140 is considered standard, right? So that means that you're good to go. You don't have gestational diabetes. Insulin resistance is not showing up in your body. A blood sugar level of 140 to less than 190 signals the need for that 3-hour glucose tolerance test. So it's like, ooh, you're borderline. We should probably look into this a little bit more in order to actually diagnose gestational diabetes. If you have a blood sugar level of 190 or higher, that's going to indicate gestational diabetes. And anyone at this level is going to need to monitor their blood sugar at home before breakfast and after meals and figure out a plan with their care provider. They may not need to take insulin injections if they can find a way to keep their blood sugar under control with diet and exercise. So there are some recommendations. So if the blood sugar testing shows that you have GD, they will recommend that you exercise 30 minutes a day or 150 minutes a week, and especially after you eat. Right? So after eating carbs or after eating sugars, if you go on what people call like a glucose walk, it helps your body metabolize those sugars. So especially right after eating, going on a walk, climbing some stairs, doing something for at least like 10 to 15 minutes can really help your body manage the blood sugar levels. There's also what's called a gestational diabetes specific diet. Usually they're going to recommend that your client meet with a registered dietitian and kind of go through this specific diet plan. Generally, recommendation is going to be a lower intake of high sugar foods. Makes sense, or simple carbs for people to eat a reasonable amount of carbs each day, so usually lowering their intake, and have many small meals throughout the day instead of a few large ones, which can cause your blood sugar to spike. So there's going to be a lot more monitoring, a lot more paying attention to food intake, and patients with GD definitely have a higher risk of disordered eating, especially if they have experienced disordered eating before, because this requires them to be so hyper-focused on their food intake. And the more severe the GD is, the more restrictive their diet is going to have to be. So definitely watch out for that, and that could be a space for good emotional support from a doula, or maybe they are feeling overwhelmed with kind of making a plan for food, and you can help them with that, because sometimes the dietitian will give them the plan, but actually actualizing that and making it a reality is something they could use some practical help with. So know that that's a place where you could step in as a doula. All right, so now we're going to move into talking about amniotic fluid levels, or AFI. So what is amniotic fluid? So amniotic fluid is that straw-colored liquid that surrounds the baby in utero. It is made from maternal plasma and later from fetal urine as well. The fetus swallows the amniotic fluid and then pees it out. One of the main functions of this fluid is to protect the baby from impact to the birthing person's belly. So it's this pool or balloon that kind of protects the baby. It also contains nutrients and has antibacterial properties. So the baby's swimming around in that amniotic fluid. So how are amniotic fluid levels measured? Generally, we're looking at using an ultrasound. The technician looks for the deepest vertical pocket in each quadrant and sums them for the AFI number. So they're looking at each quadrant and then summing the depths. There are 2 ways to sort of assess how much amniotic fluid is available to the baby, right? So one assessment is the SDP, so single deepest pocket. This is a measurement of the deepest pocket of amniotic fluid by centimeter in a single quadrant of the uterus. The idea being that if the baby needed to, they could go into that kind of deepest pocket, right? That's what is available to them, right? And then we have AFI, so that's amniotic fluid index. This is that sum of the total measurement of the deepest pockets of fluid by centimeter in each quadrant of the uterus. So those are two just different assessments, both done with ultrasound. So normal values for that amniotic fluid index. Um, Polyhydramnios, so having like too much fluid, is going to be anything that is 25 centimeters or greater. Normal range is going to be 9 to 25 centimeters. Borderline, kind of getting a little bit too low, but not quite oligohydramnios or like the very, very low. It's going to be 5 to 8 centimeters. And then that oligohydramnios is less than 5 centimeters. And again, this is AFI. So they're looking at 4 quadrants and summing those values. The normal values for that SDP, or single deepest pocket measurement, for polyhydramnios, we are looking at, okay, 16 centimeters or greater, that's severe poly, right? Moderate is going to be 12 to 15 centimeters. Mild is 8 to 11 centimeters, and normal is less than 8 centimeters for that single deepest pocket. So that's when they're looking at the one single deepest pocket in one of the quadrants, right? So it makes sense that would be lower than AFI, because AFI is a sum versus a single deepest pocket. So how accurate are these methods actually? Neither is very accurate, especially in the third trimester. Accuracy can be dependent on the experience of the technician, how much pressure is being applied, and what position the baby is in. AFI tends to be better for identifying polyhydramnios, so having too much fluid. SDP is better for identifying oligohydramnios, or having too little fluid available for the baby. But generally, research shows that SDP should be that preferred method. There really is not an agreed upon lowest value that predicts poor outcomes. And it is notable that amniotic fluid levels always drop as someone nears labor and birth, right? So there's less space in there, and more baby, right? So it's normal for those amniotic fluid levels to drop. So what we're trying to help discern with our clients is like, is this just part of the normal dropping of fluid or right before labor, or is this actually a chronic problem that we need to induce for? This is just a normal trajectory of amniotic fluid levels in a singleton pregnancy. So usually that fluid will peak around 29 weeks and then declines until birth. So it just keeps going down as that baby gets bigger. So what causes that lowering of amniotic fluid at term? If a mother is dehydrated, this may lower amniotic fluid levels, right? So not enough water in them for the birthing person. People are more likely to be diagnosed with low amniotic fluid levels during the summer. That's also possibly because of that dehydration. If a person with low amniotic fluid levels at term drinks at least 2.5 liters of fluid per day, she'll increase the likelihood that her amniotic fluid levels will be up to normal by the time of delivery. So there are things you can do. Hydrate. Also, if a birthing person rests on their left side during that fluid measurement or before that fluid measurement, that can increase amniotic fluid levels. Helps with just the flow of liquid, blood flow, all those things. Left side is the best side. If the birthing person's water has broken, so membranes are ruptured, that will lead to a decrease in amniotic fluid. Makes sense, water is leaking out. If a person's placenta isn't sufficiently doing its job anymore, this could lead to a decrease in amniotic fluid. And that could be due to some of those other things that we have been talking about, like preeclampsia, or intrauterine growth restriction. So the placenta's, not giving the baby enough nutrients. The other reasons that we could have a lowering of that amniotic fluid at term is that maybe the baby is having some trouble with their urinary system or their kidneys. That could decrease the flow of urine. But it also could be normal that 14 days before the start of spontaneous labor, the baby's urine output starts to decrease. So we're kind of working on that with our medical providers. Like, is this just normal, or is there something else happening? Also, as the baby gets closer to term, the baby swallows more amniotic fluid, which leads to a decline in fluid levels. And if the baby is post-term, so after 42 weeks, they begin to swallow significantly more fluid, contributing to that decline. And then finally, if the baby has a birth defect of some kind, they may swallow significantly more fluid, leading to those low AFI levels. So there's a number of reasons why we could get this lowering of amniotic fluid. Some of them are very normal, and then some of them require, a potential induction, or it might be just a signal that something else a little bit more severe is going on. So going back to talking a little bit about polyhydramnios, so we're going to go into detail here. That just means there's too much fluid in the uterus during pregnancy. Sometimes people will feel just like, wow, like I've had a baby before, but now like my skin just feels like it's being stretched. I'm just feeling so much bigger than I did last time. And that can be because there's just so much amniotic fluid in there, right? The causes are mostly unknown, right? So we need more research on this, but it could be a genetic anomaly 18% of the time, or there could be other conditions, infection, placental issues, blood incompatibility, all these kinds of things. Impaired swallowing or increased urination, placental issues, fetal heart condition, or maternal diabetes. All of those could be part of the equation. So again, this is the reference chart you can see on the right. So, mild, moderate, and severe poly is going to be 8 to 11 centimeters. Is mild, moderate is 12 to 15 centimeters, and severe is 16 centimeters or greater with that SDP. And it's always good to ask for them to do an SDP instead of an AFI or in addition to an AFI, so you get all those numbers, right? If we're looking at an AFI reference chart, it's going to be 24 to 30 centimeters for mild poly, 30 to 35 centimeters for moderate, and over 35 centimeters for severe polyhydramnios. Some of the symptoms of this will be trouble breathing, swelling in the legs and vulva, tight belly, as I said, right? Just feeling expanded, irritable uterus, fetal malposition because there's so much space, right? So babies can hang out breech very easily. And then increased constipation and heartburn just because, there's so much more compression inside. There's just more inside pressing on the birthing person's body. The treatment would be increased monitoring, so NSTs or non-stress tests to monitor the fetal heart rate, blood pressure, things like that. A BPP, which is a biophysical profile. It's a very in-depth ultrasound to look at the baby's functioning. Diet would be similar to a gestational diabetes diet. And then finally, induction. Sometimes polyhydramnios leads to unnecessary induction if it looks like something might be up with the baby. Oligohydramnios is the opposite, too little fluid in the uterus during pregnancy. So again, the causes could be fetal kidney or urinary problems, insufficient placental flow, water breaking, maternal dehydration, diabetes, or hypertension, or just a post-dates pregnancy. You've been, pregnant 41 or 42 weeks, right? So the kind of severe level of oligo is going to be less than 5 centimeters. And then a moderate is going to be 5 to 8 centimeters, and normal AFI is going to be 8 to 12 centimeters, right? So there's kind of a range there. Unfortunately, there aren't any external symptoms to watch for with oligohydramnios. It only affects about 4% of pregnancies, so it is fairly rare. Risks are more severe the earlier in gestation the fetus is. So, if this is happening earlier in the pregnancy, then we're like, oh, something is going on, because we know that there's some normal lowering of fluid levels as we get towards the very end of pregnancy. So that's a lot more normal, right? But we're seeing this earlier in gestation. We know that something else might be going on. We need to do some more testing. So it can be correlated with IUGR, preterm birth, stillbirth. That's rare, but more common if severely preterm. And then during labor, when we don't have enough fluid in there for the baby to kind of freely move, we worry about cord compression, right? So there's not enough buoyancy to keep their baby off the umbilical cord so they can actually cut off their own blood supply. And then because of that, we can see more babies pooping inside before coming out because they tend to poop if they get stressed out. So we definitely see more meconium stained fluid, which can lead to a higher risk of aspiration when they come out of that poop. So the treatment is going to be maternal rehydration. So maybe some of it is dehydration. So really help your birthing people stay hydrated. An amnio infusion would just be putting more water back into the uterus, and they can do that if the water has broken. So usually that is if you're already, being induced or in labor. Again, they'll want to do increased monitoring to make sure everything continues to look okay, baby's doing all right, and they may recommend an induction, especially if we're seeing this a little bit earlier. It just shows that the systems are not functioning as we would like them. So what is the evidence for induction for low AFI at term? There's just a few things to pay attention to. So Rebecca Decker, who's a PhD in RN, she found that evidence-based birth, wrote this kind of cheat sheet for evidence for induction for low AFI. Can potentially help your clients. So one would be that remember that ultrasound measurement is a poor predictor of actual amniotic fluid volume. And we should always ask for that single deepest pocket method of measurement because it has fewer risks than AFI. So that's her language. What I take that to mean is that if we get that single deepest measurement, that's going to be a little bit more accurate in telling us whether or not we should induce, that would actually lead to better fetal outcomes than the AFI numbers. Poor outcomes seen with low amniotic fluid are usually due to underlying complications such as preeclampsia, birth defects, or fetal growth restriction. And then the main risk of low amniotic fluid at term in a healthy pregnancy is induction and cesarean delivery as a result of that induction. And potentially the risk of lower birth weight because we've, kind of sped up the timeline, right? So current evidence does not actually support induction for isolated oligohydramnios at term. So unless we're seeing other things going on, this might not be the strongest evidence for inducing. So it's a hard kind of area to navigate with clients because there's that gray area, right? Where it's like the evidence might not actually point to this being a necessary induction. So we definitely need to have more conversations with our medical provider about, what is actually going on with this baby. So while we're on the topic of talking about amniotic fluid, we're going to talk a little bit about the norms for rupture of membranes or when your water breaks. What's important is looking at the color. So normal color is going to be clear or slightly yellow. So we always say like straw colored. Clear plus a little bit of bloody show is going to look very like lightly pink. That's also very normal. If your client is still at home and doesn't have any other risk factors, like let's for example, as GBS, so just group B strep, where you would need to get some antibiotics when you go into labor, this would be a great sign that they could stay home, right? So this all looks normal and healthy. Abnormal would be seeing green, brown, which would be kind of like light, medium, and heavy meconium you can see here. So we don't want to see that. That would be just a good reason to go get checked or have the baby be monitored at the hospital. It could be totally normal, especially for a baby that's late in their gestation. So after 40 weeks or so, their digestive tract is way more mature. So they may have pooped in utero just because of that. But they also could have pooped in utero because they got stressed out at some point. And so that's kind of what we're checking on. It's like, hey, are you doing okay in there? So that's just what meconium might look like. And then another version of abnormal would be if you're seeing bright red blood that soaks two menstrual pads within an hour. So that would be more along the lines of how much blood you would see if there's a placental abruption or the placenta is starting to come away from the uterine wall. It would bleed a lot, right? And so if we're seeing bright red blood that soaks two menstrual pads within an hour, clear sign that we need to go into the hospital at that point. This is different than kind of wiping and seeing some bloody show or um, seeing, a lot less than this two menstrual pads within an hour. That kind of bloody show is showing us that the cervix is changing and dilating, softening, effacing. So that can be a really healthy thing. If they are worried still about that blood, you can have them kind of text a picture to their medical provider to kind of confirm that, yeah, this is just a healthy amount of bloody show that's showing that you're making progress in labor and you're still good to stay home. Here's a picture of an actual pad that someone probably texted their doula or midwife to find out whether or not there was meconium in this fluid. And so, what would you say? Can go back to the picture before and then forward to this one. So this one, there is some meconium in this fluid, and it might be a good idea to just get checked out. It could be nothing, it could just be an older baby, but for peace of mind, get checked out. The other ways to kind of confirm whether or not someone's water has broken would be the Fern test, so they might do that. If it's unclear whether or not someone's water has broken, they can just look at it underneath a microscope, and amniotic fluid will fern like this, right? There's also the pH test. So this is another really simple test. With pH paper, they're going to find some amniotic fluid, whether or not that's on a pad, or maybe it's kind of like dripping down someone's lip, and they'll swipe through it and it turns purple, then that would mean that amniotic fluid is likely present. So those are ways to kind of confirm that the water has broken, right? So those are just some different tests that it's good to know about for your clients. All right, so the last thing we're going to take a look at is what is normal for a fetal heart rate. And there'll be a monitor in the hospital room that will be showing both the fetal heart rate as well as the contractions. Because we want to be able to know how is this baby reacting to these contractions, to this labor. So a normal range for a fetal heart rate is going to be between 120 and 160 beats per minute. If your client has a Doppler, so that's something that they can use to listen to the heartbeat at home, or you have trained as a monitrice, which means that you are trained to use the Doppler and listen, what you will do is find the baby and then count the heartbeats for a full minute, right? And listen 3 times. So do that 3 times. You don't want to do the same thing as you would with an adult because fetal heart rate is more variable. So instead, you are going to actually listen and count for that full minute at a time in order to assess, right? So instead of listening for 10 seconds and then multiplying by 6 to get your number, you're going to listen the whole minute. Tachycardia is having too high of a baseline fetal heart rate. So that's going to be a baseline that is 160 or more beats per minute. The causes would be maybe there's a really strong infection. So if there's infection brewing in the maternal body, or we have some placental issues. Then we also have bradycardia, which is too low of a baseline fetal heart rate. That's going to be less than 100 beats per minute, right? The causes for this would be less blood flow to the placenta. That could be due to cord compression. Maybe the birthing person has been on their back for too long and there's compression of blood flow that way. It also could be a really great sign of progress, though, that the baby is engaged in the pelvis and it's actually time to push. So the baby's telling you, like, my head is getting squished and it's time to be born. So it could also mean something like that. So we're going to help you learn to kind of decipher and read and help your clients translate what is going on the screen. So a very helpful way to remember what is happening with each of these kinds of decelerations or acceleration is this tool called veal chop. So veal is VEAL, and that kind of is the fetal heart rate pattern. And then the cause is CHOP, CHOP, and then management, finally. So I'll walk through each of these to make them a little more clear. So V goes with C, right? So veal chop. V, variable deceleration, could be a sign of cord compression. The way that we treat this is by moving the birthing person, right? So maybe the position that they are in is causing that cord compression. So the baby is laying on their cord or pinching their cord or holding their cord in some way, and usually moving the birthing person is the way that we fix that, right? So instead of just going like straight to cesarean or straight to some other intervention, we move the birthing person, right? Then we have early deceleration. So this happens before the contraction happens, right? And that would be a sign of head compression. What is the head being compressed by? Usually the pelvic floor or the pelvis, pelvic bones. And that usually means that labor is progressing, right? It often will mean that it's time to have a baby. It's time to push. It's a great sign. And then we have accelerations. These are also very healthy, right? So they're okay. So that's why A goes with O, okay. N, no intervention needed, right? And then finally, we have late decelerations, which happen towards the end of a contraction. And that goes with P, and stands for placental insufficiency. So something about what the placenta is doing is not efficient, is not giving enough blood flow and oxygen to the baby. And this is the most concerning kind of deceleration. And that goes with E, which means execute actions immediately. So we need to do something to support this baby. And this is the type of thing where it may be more likely to move to an emergency cesarean a little bit more quickly than we would need to. Babies can tolerate this for a time, but they can get tired, and we don't want them to get to the point where they're sort of at the end of their rope. And they're using, the last of their oxygen. So this would be a little bit quicker of a conversation about a necessary cesarean. So this is sort of what you might see on the screen, or a version of this, right? It's not going to have the kind of like titles of acceleration, variable deceleration, or late acceleration, but this shows you a snapshot of that would look like on the screen in the hospital room. So first we have the accelerations, and again, these are great. This shows that the baby is reactive, they're energized, they're doing fine. And you see these abrupt increase in the heart rate from baseline. And baseline is just kind of like, generally, if we were to draw a line, a kind of average line through these heart rate numbers that we're getting, then that's sort of your baseline right there. And so you see these little abrupt increases in the heart rate from the baseline that are, occurring anytime during labor. That's a really great sign, right? It's a reassuring sign of fetal well-being. So we can see these maternal contractions are going up and down, and we're seeing these nice accelerations. That blue area on the screen is going to, or shaded, whatever color it's shaded, it might be different in different hospitals. That's going to be sort of outlining the normal range of heart rate. So give us a pretty clear visual. And then we have variable decelerations. So that would be an abrupt decrease here in the heart rate from the baseline. And that variable, that word means that it varies with contractions, or the onset of the decelerations is not happening like always early or always late. It's sort of a little bit more sporadic. And that can be pretty common, and it can happen in, 83% of labors. And so again, you usually just help the birthing person get into a new position that is better for blood flow, and it's fine. Then there are late decelerations, right? So here in this like red column, these are gradual symmetrical decreases in heart rate. and that happens kind of towards the end of a contraction, and the heart rate returns to baseline after that contraction ends, right? So the onset here you can see occurs at the peak of that contraction. That could indicate fetal distress if it's repetitive or severe. So if we see a really deep dip, and you'll be able to hear that slowing down of the heart rate. If it kind of goes down and then comes right back up, and we know that that baby is, responding well, might be time to push, we'll see. But if it's pretty severe, that could just mean that, it's time to have a baby one way or the other. So here's a test for you. I want you to pause the video, take a look at this chart, and then write down what you think this kind of deceleration is. So go ahead and pause the video. All right. So this one is an early deceleration. So we can see that it is at the onset of the beginning of the contraction. It goes down with the contraction and comes back up, right? And these early decelerations, they're uniform shape. They kind of match the contraction, right? So they dip with the contraction as the contraction rises. And that usually is a good sign of head compression, and that it's might be time to push a baby out soon. So great sign of progress. All right, here's the next one. So pause the video, write down what kind of deceleration you think this is, and then come back. All right, we've moved forward in time, and this is a late deceleration, right? So you can see that the onset kind of starts at the peak of that contraction and goes down as the contraction starts to wane, and there's this late recovery, right? So it's not symmetrical with your contractions. And this is going to show us that maybe there's some placental insufficiency. All right, pause again, read through this chart, and make your guess of what kind of deceleration this is. And coming back. So this one is a variable deceleration. This could mean that the umbilical cord is being compressed in some way and we just need to move the birthing person, right? So we can kind of see they're happening a little bit sporadically. There's a rapid drop and come back up, right? So you see it's a little bit sharper, less scoopy than the early and late decelerations. And so this just means we need to move into a different position, at least for a time. Finally, we have this cheat sheet that you could use with your clients to kind of explain what is going on. You may print something like this out and either take it to your prenatal visit with them. You can do some education ahead of time. Sometimes when people don't know anything about the different kinds of decelerations, they all feel really scary, right? And so if you feel like your client would benefit from some of that prenatal education, you can bring this in and show them what is going on so that they can read the chart or the computer that's kind of next to them. Otherwise, sometimes it just feels a little bit overwhelming and overstimulating, but a little bit of education ahead of time can ease their mind. Many times they will want the education in the moment too, because they'll learn it once and then once they're actually in labor they'll forget, and it's just good to have some of the reminders and have you there to kind of help explain what is going on. That like not all of these deceleration are dangerous or worrisome or mean that we need to go have a cesarean, but some of them are, right? And we need to be able to act on those. And there are some hospitals where maybe the nurse isn't paying attention at the station and you notice that, oh, we're having these significant decelerations, like what's going on, and nobody's coming. You can also call the nurse in or call the doctor in if you notice some alarming patterns. So sometimes, depending on where you are, you'll need to be an advocate for your clients and make sure that they get the help that they need or they move into new positions to kind of protect that baby. So you can make your own cheat sheet or teaching tool or print out something like this that you offer them at your prenatal visits. Um, After watching this video, if you have any questions, anything that needs clarification, feel free to email me at doulahanna@gmail.com.